Good morning, everyone. We have plenty of time for this session for discussions. May I invite Professor Ayman Al-Tabba to give us a very decent, eloquent, clever talk about syndesmotic injury.
Thank you, my dear Professor, Dr. Wageen Musa, for this very nice presentation and invitation. Thanks a lot. Happy to be with you again in this elegant Congress. And my lecture is going to be about the syndesmotic injury. I'm going to speak about the acute syndesmotic injury and make hint about the chronic syndesmotic injury. About the acute, as we know, the syndesmosis, syndesmotic tear, means disruption of the distal tibiofibular syndesmosis. The incidence 1 to 18% of the ankle sprains and up to 50% of type C fractures. So please, when we see high fibular fracture, search about the syndesmosis and you need to confirm is it injured or not. The clinical importance is to maintain the ankle mortise congruency because 1 millimeter lateral shift can cause 42% decrease in the tibio-talar contact area, and this will lead to post-traumatic arthritis if mal-reduced. The mechanism of injury, it's like the pivot shift of the ACL, which can occur in the knee, but it's a pivot shift at the level of the ankle, where the primary mechanism is external rotation of the foot relative to the tibia, as during football tackling, for example. If a patient presents with high fibular fracture or deltoid ligament injury, you must suspect with high incidence of suspicion the syndesmotic instability as well. How we can diagnose it clinically? There is no single test is perfect, so you need to combine the examination test, including tenderness to palpation over the AITFL and interosseous membrane and swelling at this area. The squeeze test, it has low sensitivity 30%, but actually high specificity 90%. And the external rotation stress test of the foot, where the patient say I have pain at the syndesmosis area. About the X-ray, please remember if you are going to do the standard X-ray, non-weight bearing, then you are going to lose 50% of the unstable injuries or 50% of the latent diastasis as the syndesmosis. As the fibula often reduces spontaneously when non-weight bearing position. So you need to do weight bearing X-rays or stressed X-rays. As we can see here, this is the hand for where you fix the leg and move the foot into external rotation. The external rotation is stress view. You are looking at the tibiofibular clear space. If it's more than 6 millimeters, this is pathologic, and it's the most reliable marker. Also, the medial clear space when it's more than, here, the medial clear space when it's more than 4 millimeter, or when you see that the medial clear space is more than the superior clear space. And remember, not in equinus. When the X-ray in equinus, you may find in some cases some laxity as the medial clear space. Instead of the external rotation stress view, you can do the gravity stress view. It's more comfortable to the patient, especially the acute and the fractured patient. Advanced imaging like CT is essential for assessing the bony architecture if there is avulsion or tilo-chapeau. Compared to the contralateral side, if more than 2 millimeter difference is pathologic. And very interestingly, the weight bearing CT, we are waiting it to come soon. It's a new reference standard, very, very effective in evaluation of the syndesmosis, sensitivity 95.8% versus the conventional methods. It detects the subtle widening under load. When the patient stands, then there is load and stress, and you can see by the CT, weight bearing CT, clearly the syndesmosis injury or diastasis. The MRI, excellent for the anatomy, 93 to 100% can detect the AITFL tear, but it has poor correlation with the functional instability. Is this tear or the sprain had made really functional instability and diastasis that need surgical intervention or just non-operative treatment? This answer can't be done by the MRI alone. The rule of arthroscopy, it's a gold standard, superior to fluoroscopy for the dynamic evaluation of the ankle, of the syndesmosis. And there is the drive-through sign where you are able to pass the 2.7 or 2.9 millimeter scope into the joint space, or you can introduce a blunt trocar into the syndesmosis area. If it introduced and go inside the syndesmosis, then this is pathologic. It's easy to do. This is the talus, this is the tibial plafond, this is the lateral malleus, and here the syndesmosis, where you can, by the probe, I don't know if you can see it clearly or not. It's better here on the laptop. So the syndesmosis, this is the syndesmosis, and you can stress it with the probe. The arthroscopy not only can detect the injury, but you can debride the ligament stump if it's blocking the reduction, and also you can address the associated chondral lesions as well. How can we make the reduction, and how can we confirm the diagnosis intraoperatively? If we can look here at this X-ray, can we say if the syndesmosis is injured or not? For me, I can't confirm till now. I have learned this test from my professor, Dr. Wagim Musa, which is the drill tap test. You drill the lateral malleus and you tap the lateral malleus, and through the tap you are pushing the tibia and see if there is diastasis occur or not. And now very, very clearly I can see the medial clear space widening and the syndesmosis widening, so I fix this syndesmosis. About the intraoperative proper reduction, should I do it open or closed? The open reduction is preferred by many of our professors and AO professors. The Professor Dr. Ahmed Khalif always tell us that he prefers the open reduction of the syndesmosis to see clearly the incisura and to remove the debris. There is a paper speaking about the clamp placement and where is the ideal position of the tens of the clamp. The error that is common when we just put the clamp on the lateral and the medial, that you can make internal rotation of the fibula and anterior translation. And they recommended in this study to make the ten or the limb of the medial limb on the tibia to be in the anterior third. So, as we know, the fibula is posterior to the tibia, so this is considered the axis to make the direction of the reduction in the syndesmotic axis. The 10 of the medial or on the tibial side should be in the anterior third. If there is O-arm, which is intraoperative 3D imaging, this is ideal. This is perfect, fantastic. The model reduction rate with the fluoroscopy alone is 52%. So what you can see in the C-arm is anatomical reduction is actually in 52%, or in this study they are saying that after reduction using the fluoroscopy and finding that everything is nice and anatomically reduced, when they use the O-arm they find, as you can see, anterior translation in some cases, posterior translation in other cases, and over-compression in other cases. And they need to do revision in 33% of what they thought perfect looking reductions in the CR. How to fix? This is always the debatable issue. Construct 1 or 2 screws, 3.5 or 4.5. Still no significant biomechanical differences between 3.5 or 4.5, 3 or 4 cortices. What about the the bruise of the screws? It's ineffective, rigid, and we are all familiar with its use. But the cones, it need removal, either routine or in demand when the patient is asking for seeking of pain, or sometimes limitation of reaching the maximum dorsiflexion, or risk of breakage. So the patient must be notified about this if not planning for routine removal. It locks the fibula, so there is risk of over-compression after using the screws. But what about the flexible or dynamic fixation like tight rope? The mechanism is tethering, causing flexible stability, allowing some physiologic micro motion, and it has superior functional scores, higher OFAS and OMAS scores at 1 and 2 years post-operative, with faster return to sport at 14 weeks versus 19 weeks for the screws. The advantage, lower reoperation rate. You don't need to remove unless there is pain or irritation sometimes of the soft tissue. It minimizes the malreduction because the fibula settles into the notch, and sometimes it can correct itself after incompletely perfect reduction of the syndesmosis intraoperative. The cost is higher, actually ambulant cost, but they consider this, it has lower total cost of the care as it avoids the second surgery according to the parameters of the Western cost, the hospital cost. What about the double suture button or hybrid? Some studies have support not only using one suture button but two suture button construct for the complex or high energy injuries to improve the stability and correct more the rotational instability of the syndesmosis. Associated injuries: posterior malleolus fracture, deltoid, Maisonneuve, osteochondral lesions. For the posterior malleolus fracture, fixation of posterior malleolar fracture restores the syndesmotic stability, and it may even eliminate the need of transsyndesmotic screw after fixation of the posterior malleolus. When you test the syndesmosis, you can find that the stability has regained just by fixation of the posterior malleolar fixation. About the deltoid injury, common in severe syndesmosis, as you can see here in very large media clear space. The surgical repair nowadays is recommended much more than the classic teaching, where we were taught that you don't need to repair the deltoid unless it blocks the reduction. But now there is a lot of recommendations of repairing the deltoid, as you can see here in revision of this patient with syndesmosis instability and deltoid. It's sleeve avulsion and restoring its the deltoid function can support strongly the rotational stability of this ankle, not only by the syndesmosis reduction. Maisonneuve, as I mentioned, high fibular fracture with syndesmotic disruption and medial injury requires syndesmosis stabilization and medial repair. Actually, in my practice, sometimes I find that I can't restore the syndesmosis reduction except after reduction of the high fibular fracture. I don't know if our professors and experts have similar or different experience, but sometimes you need to restore the fibula so you can restore the length of the lateral malleolus and its relation to the incisura. The osteochondral lesions, the incidence up to 22 to 25% in acute and chronic cases, detected better by the scope and CT and sometimes MRI. What about the chronic syndesmosis instability? If there is static diastasis, you need to do anatomical reduction of syndesmosis before fixation. You need to restore the congruent ankle mortise. You need to do debridement of the syndesmosis, removing debris, debridement of the medial clear space because a lot of fibrosis occur in the medial clear space in chronic cases, and do deltoid repair in cases of valgus instability. Examples of publications about this: John et al. In 2008 had made the arthroscopic debridement for 6 patients, and using 2 cortical screws, the OFAS scores showed statistically significant improvement in these cases. What about the buttons? Powell et al. In 2015, 19 patients diagnosed instability by arthroscopy if it opened more than 4 millimeter. If he introduced a probe with transverse diameter of 4 millimeter, considered unstable, and fixed it using debridement and using end button fixation, the OFAS score improved significantly from 48 to 82.7. Other options, not only fixation, yes. We can do AI-TFL retention in chronic cases, like Boimer et al. In 2000, 9 cases, medial and proximal advancement of boom block at the anterior tibial tubercle, making screw and adding screw also a syndesmotic screw. The old patients improved in his study. Similar results were observed in Wegner et al. In 2011 on 12 patients, and Colcook et al. In 2016 on 10 patients. The third option in the chronic unstable syndesmosis with static diastasis is ligament reconstruction. Using autograft, for example, Hani et al. In 2021 has made systematic NICE review, including 5 studies, including 51 patients. The options were peroneus longus, hamstringis, plantaris longus, with 99.8% complication rate. Just 1 minute, please. Okay. These are examples of the papers made, including the ligament reconstruction, the split peroneus longus tendon, the Grassi et al. In 2003 reconstructed not only the anterior and the posterior tibiofibular, but also the interosseous tibiofibular ligament, making 3-point fixation of the fibula. But as we can see here, he made 2 tunnels in the fibula, and this increased the risk of the atherogenic fractures. He made this for 16 patients, and the mean Carlson score at the time of follow-up was 88. Other option, yes, hamstring, Mathieu in 2009, 8 patients, post-operative office score was 85.4%. What about the arthroscopic? Should it or must it be open? It can be done also arthroscopically. This will improve the accuracy, minimize the invasiveness, allow the cartilage evaluation, of course, but to our knowledge, still no case series has been published, just surgical techniques. Examples of this, Tony et al. In 2010, syndesmosis reduced and under arthroscopic guidance, transfixed with syndesmotic screw, and then tried ligamentous reconstruction, anatomical using half of peroneus longus graft. While Vila et al. In 2017 made surgical technique to syndesmosis stabilized using 1 or 2 suture button and used the gracilis or extensor hallucis longus allograft. It's simpler. He reconstructed only the AI-TFL. It's simpler than the previously described reconstruction. Single fibular bone tunnel, of course, reduce the risk of atherogenic fracture, and incomplete or blind tibial tunnel, which avoids the risk of damage to the neurovascular structures, as you can see here. And this is another paper, Song et al. In 2017 also. Again, surgical technique without case series, syndesmosis reduced, fixed with biodegradable syndesmotic screws, tibialis tendon allograft with biotenodesis screw for the fibula and biotenodesis screw for the tibia only, AI-TFL reconstruction, recommended for the proper case of only anterior diastasis of distal tibiofibular joint. Again, arthroscopic, but without tendon graft, he used the corkscrew suture anchors, no need for graft. He didn't use other syndesmotic fixation prior to reconstruction. But remember, suboptimal tensioning of the suture, of course, can limit the ankle dorsiflexion. What about the syndesmotic fusion? There is a rule of syndesmotic fusion in chronic syndesmosis instability. Yes, but shouldn't be prescribed for healthy active patient. We should be consider it as a salvage option for incongruent joint or after failed ligamentous reconstruction, and it may cause limitation of ankle range of motion with theoretical risk of ankle arthritis. But the accelerated ankle degeneration because of changing biomechanical is still theoretical. Up to our knowledge, no evidence of ankle arthritis has been reported in literature after fusion in the midterm follow-up results. Examples of the syndesmotic fusion, Christina et al. In 2011 on 10 patients have found significant improvement in radiographic and functional measures of outcome. The reduction under arthrodesis is a viable alternative to ankle arthrodesis, was the conclusion of this paper. Also, Tunhing et al. In 2015 have described the arthroscopic technique for distal tibiofibular syndesmosis. He utilizes the proximal anterolateral and proximal posterolateral portals, and they recommend that intra-articular and extra-articular approaches can supplement each other to achieve the successful fusion. Also here in Song Etel, in 2020, 8 patients with frank syndesmotic instability. He used pre-contoured blade fixation with good clinical short outcome results. So the take-home message, diagnosis is multimodal, clinical stretch X-rays with bearing if available and MRI. Reduction, anatomical reduction is the first predictor of outcome. Open or arthroscopic reduction with 3D imaging reduces, of course, the errors. Fixation, suture button, the evidence support better scores with faster return to sport. The screws remains a valid cost-effective option. For the chronic cases, there are many options, including debridement and refixation using sutures, suture buttons or screws, syndesmosis retention or reconstruction, and syndesmosis fusion is as a salvage option. Thank you.
Thank you very much indeed, Dr. Ayman. We have some time with us because the next speaker, Dr. Ahmed Khidr, has pulled out for some unexpected circumstances. Any question to Dr. Ayman before we go to our next speaker? No? اتفضل. ميكروفون لو سمحت. صوت لو سمحت. اتفضل.
arthrodesis which you mentioned at last, if we fix the syndesmosis with
لو سمحت اتفضل من الأول تاني.
the aim of arthrodesis, it will not allow patient to weight bearing. It will not break the screws as we fix the syndesmosis in the primary injury and allow patient to weight bear after 1.5 months. The questions, if we are aiming for fusion of the syndesmosis with the plate or 2 screws, how we will keep the patient, is he allowed to weight bear, or we will postpone weight bearing for 6 weeks or 1.5 months and allow him weight bearing after that?
Transfer the question to my professor, Dr. Wagee Musa, because I don't have experience.
What's the question?
Should you allow early weight bearing after syndesmosis fusion using the plate, or you would prefer to wait the 6 weeks till healing of the syndesmosis?
What happens if you go for early weight bearing? Do you have mechanical structures to support the weight? Unless you have mechanical structure to support your weight, I always be very reluctant and careful. It's like any other soft tissue injuries. If you weight bear early, then you are at risk of failure. Now, the question which is important is you have someone with syndesmotic injury. How do you say I'm going to do fusion or I'm going to do reconstruction? This is a trick. So you have got someone with Weber C or whatever and had was treated, but they did not address the syndesmosis. If they come after a year and they have symptoms of instability, would you fuse them or would you reconstruct them? I'll ask this question to my colleague here, Venue.
Now, the French experience is not very good on syndesmotic because first we operate every fracture. There is no discussion. There is no orthopedic treatments. So we don't have a lot of chronic lesion of the syndesmotic. And in my experience, today my experience is when they use a mini-invasive approach for the plate, for the fibula, they are not opening the fracture, they put a plate and there is problem. So 20 years ago, when I was doing trauma, we were opening everything, and the reduction was perfect. And we have much less complication at the level of the syndesmosis. So that's one of my questions. Do you see more problem because of this mini-invasive? I'm really for mini-invasive, but not in this case, for mini-invasive fibula plate, when you just put 2 screws on the top, 2 screws on the bottom, and you don't check really on the fracture. That's my first question. Is there more syndesmotic lesion in this case? And the second one, because in the UK, as you know, a lot of treatment are orthopedic treatments. I saw not a lot, but once a month, chronic lesion, but because it's a flat foot. So I think if you don't fix the flat foot with the insoles, when you let them weight bearing, you push on the fibula, and if there is a problem at the level of the syndesmosis, we will have a problem in the future. So that's my second question. Do you see more syndesmotic, chronic syndesmotic lesion in with non-operative treatment if the patient has a flat foot?
اتفضل دكتور احمد خليفه، عندك اي كومنت يا فندم؟ دكتور ايمن، الدكتور احمد خليفه.
Definitely, I think it is more according to the patient needs. We need to adjust because syndesmotic fusion in an active young or definitely is not not the best option, as I agree with my colleague Dr. Ayman Al-Tabbah. But sometimes, you know, if you have a neglected syndesmotic injury in someone who is, you know, like his job does not require him to move a lot or something, it gives him an option to get that. But sometimes, how far is it completely displaced and open ankle, or because neglected syndesmotic injuries can be just a mini movement, but there is no wide displacement between both. You can open, I open some. Sometimes you find lots of fibrous tissue and the fibula is away. It's not sitting there. And some other lesions, it just move, anterior part of the injury or lesion, not complete there. In these instances, if I find no much displacement and I find that there is a hope for this to come back to its place, I just try to fix it by whatever means. I use local tissue, like Dr. Ayman said, the remnants of like osteoperiostea flap, I take it and I fix one to the fibula and one to the tibia. Just I use the local tissues, maybe if the peroneus, I take part of the peroneus, as long as just a strip of it, and use it to fix it to the tendon. If it is for widely separated, long-standing syndesmotic injuries, lots of fibrous tissue, the joint is already lost there, the syndesmosis by which I mean. Then I go there and I do fixation to the syndesmosis mix, fix it with a couple of screws. Definitely I don't wait, I wait for, because I'm aiming at fusion, so I don't allow for early weight bearing. You need to be clear, you have a clear target. If you wanted to get fused, don't allow the patient to put weight until it gets fused. And tell him that you will have some functional morbidity. It is not that much, but you will, if you are expecting to do high impact sports or to work for long distances, it might not be as comfortable as it used to be. This is my tip.
Thank you.
In trauma patient or the ankle, you do an X-ray for the ankle only. I like to do from the knee to the ankle because sometimes there is fracture proximal or middle third of the fibula, which when I find I must detect that there is most probably there is bone injury. So when you find a trauma to the ankle, you must have the whole leg. As for hip fracture, you have the whole femur. This is my opinion.
Yeah. Thank you.
Okay, I have just a small question, Dr. Ayman, because he said in Messineuve injuries, you find difficulty in putting the fibular length and rotation. So do you mean that you would go and fix the Messineuve injuries, or you go in and fix it? Yes, this is an issue that needs to be done because, sorry? I agree with you because Messineuve does not mean that this is a nice job. It means that the whole interosseous membrane has gone. The fibula is there, you have no stabilization, and you have got shortening and rotation. So definitely, what I recommend, I open, as I told you that I like to open. If I find that I could solve the thing of shortening and rotation by exposing the syndesmosis, I go and fix and neglect the upper one. If you have a neglected long-standing or for 6 weeks, the patient comes at 6 weeks or 8 weeks, it's not going to be very yieldable. Then I recommend to open it up. So I open down, try to put it back, and I'm sure if it is good, then I forget about the up. If it is not coming me, I have a very low threshold to go up and fix it. Exactly. So you don't know what it is. So I put some distraction, try to pull the fibula until I feel that the contour and the line is there. Put a temporary K-wire and then make my syndesmotic stabilization.
This is a very common mistake. When you see mesonerve injury, which is disruption of the interosseous membrane, and proximal fracture, some people go blindly and put 2 screws for the syndesmosis. They have not addressed another big issue, which is the shortening of the fibula and the rotation of the fibula. So as Dr. Ahmed said, it's very, very important to do that. Now we can move swiftly to our next speaker, Jewel Werner. Zadig's osteotomy is becoming alive now, and everyone is talking about Zadig's osteotomy.
Okay, so Zadig osteotomy, let's go. So the Zadig osteotomy is not commonly used, so I should say it's no more commonly used because with the new Percularis technique. So actually, the Zadig is one of the hottest topics on LinkedIn and in the different publication. But if you look on the publication, a lot of publications are from the same team. It's just they move the author, one the first, one the second, but it's from the same team. So why the Zadig become so popular? So first, what is the Zadig? So the Zadig is a very old procedure. It's a dorsal closing wedge osteotomy. It allows the posterior and superior angle of the tuberosity to be brought forward, reducing the conflict with the anterior face of the Achilles tendon. The Zadig has been described for the Haglund deformity. In 39, so the aim is to control the position of your eye tuberosity in a sagittal plane, initially described for vertical heel. Actually, and that's why it's become interesting, it's Percularis technique. So for Percularis technique, you need wedge burr, bigger diameter, 3 millimeter, because the 2 millimeter you may break it, wedge burr to remove more some specific instrument. So first, the technique. Lateral position, you need to remove a dorsal wedge. C-arm, always, because you can't see anything. Tight tourniquet if you require it, but there is no need of tight tourniquet. Poplite block or spinal or GA as your anesthetist. First, you have to, and that's what I like, because for teaching is very easy. You can teach your registrar. He has to come back and tell you exactly which angle. I want this to remove this angle to brought forward the eye tuberosity or to control my vertical heel. So everything can be planned before the surgery. Then as soon as you decide how much you want to remove, you put your 2 KY exactly in the position of the, we used to do drawing before the surgery. So exactly like before the surgery, your registrar can put the KY and then work between the 2 KY. Find the position under X-ray, stab incision, so 5-6 millimeters. The nerve finally is, we have done different studies, the nerve is far away, but still better to think the nerve is there. So with a clip, decision of the soft tissue, open the clip, put the burr between, full speed, the burr is in the bone. As soon as the cutting part is in the bone, you can't damage anything. And then you remove the clip and you go inside and you shave the bone until you are against 1 KY. You do your cut and then you shave the bone. You don't need to remove the bone, you just need to destroy the bone to create a paste of bone. You shave until you arrive at the second level. And when you arrive at the second KY, and we can see here that the KY at this level has been a little bit damaged by my burr. here too. So when you finish to remove everything, remove one KY to be sure you end up on cut everything. You need to keep the plantar cortex, that's very important. Then you can close it, you're happy, not happy, and then you bring forward the insertion, and then the eye tuberosity, and you fix it with one screw. But where to do it and how much to remove? So it's very important because the American, with all their publication, they misunderstand different things in the ZADEC. First, all the ZADEC are not the same. It's like today we are talking about a chevron osteotomy for distal osteotomy, but it can be extra-articular, it can be intra-articular, it can be percutaneous, it can be open. So we have to be more precise. And first here, that's ZADEC osteotomy, but as you can see, it's not at the same level. So it's not the same ZADEC osteotomy. So as I said yesterday, the position of the vertex, this position is very important, and I'm going to explain you why. So if the vertex is kept posterior, a forward rotation of the eye tuberosity is obtained exclusively. That means you don't change the angle of your calcaneus. So that's very important. If you have a flat foot with insertional tendinopathy, if at the same time you bring and you make it more horizontal, you will do worse. So you need to keep this position. It's very important. So the apex, the vertex, should be at this level. But if the vertex is more anterior, when you will remove the wedge, you will have an elevation. So you bring forward the eye tuberosity, and in the same time, you elevate the eye tuberosity. So for a canvas foot, it's very important. It's very interesting because from a vertical heel, you will have a horizontal heel, and that's why ZADEC described it, because it was a problem of vertical heel, and doing his ZADEC osteotomy was bringing forward and elevate the eye tuberosity. Then how much? The same. It will depend on the result you are expecting. So 3 situations are possible. So you have a normal hind foot with a neutral calcaneus, but with excessive eye tuberosity and a negative posterior angle beta, this part. In this case, your eye tuberosity is responsible of conflict, an impingement with the Achilles tendon. The purpose of your correction is to stop the impingement. Therefore, you must remove a piece of bone equivalent to the angle beta. That's this angle that you should report on the calcaneus. When you report it on the calcaneus, you will be able to move everything forward and stop the impingement. And end up with this position. So because the angle alpha is normal, it's really important to keep the vertex posterior to avoid the elevation I just talked before. Our second case is a vertical heel, not specifically eye tuberosity, more normal eye tuberosity, but a vertical heel. with this excessive angle, alpha angle. So if you want to correct it, you need, the best will be to have your apex at this position, so you can correct it perfectly and put it in the right position. But to do such a osteotomy, it's much difficult because it's a very long osteotomy, so it's not recommended. Maybe too close, so you may be too close to the vascular, it's difficult. So don't do it this way. But it will work, that will really the best thing to do. So how to make it work with less risk? So we need to choose another point for the vertex here. The problem is that your initial osteotomy, the measurement of your initial osteotomy is no more valuable for this because you move your vertex from here to here. That means if you use the same angle alpha 1 here, it's not possible to correct the deformity. So then how much do I need to remove if I put my vertex at this level? So that's mathematics. I'm sorry, I like mathematics. So the solution is here. So you decide here that this angle, it's the measurement we had before between the normal alpha and alpha 1. So that's our delta here. But if you report the delta here, it will not work. So the difference is sinus, you need to apply the distance. You need to measure this distance to be sure the result here will be the same than here, because that's the only thing you want is this. So the elevation A or A1A that you want is equal to the sinus of your angle multiplied by the length of your osteotomy. Then you will be able to transfer this vertex at this level and obtain exactly the same final correction. And that's the only thing we want. So, therefore, to determine further elevation I, you need to measure the length of your future osteotomy D. The angle of your wedge will be then arc sinus, where is it? It will be arc sinus A on D. So that's the mathematical result, how much you need to remove. I understand it may be like that, it's a little bit complicated, but for me it's very important because when I teach, I want my registrar to come and say, okay, I measure everything, now I need to do this at this level, I put my KY, and my result will be what I'm expecting, and that's very, very important. Not doing just remove, and at the end, or I'm happy or not happy. That's not how things work. In orthopedic, we need to plan before, and then we will be able to obtain the correction. So last case, it's a vertical heel with a high tuberosity. So then, you need to treat the impingement on the vertical heel. So correction of the, sorry, I'm going too fast. So impingement on vertical heel. So with if you move your angle like before, sorry, I come back. If you remove it here, you will be able to remove the same. You remove the high tuberosity in the same time and bring forward. So Zadek will be the solution. Post-op. I like to use a boot for 2 months, partial weight bearing the first month, full weight bearing the second month. Indication, exactly the same than open surgery. For me, I was trained as a registrar to do ZADEC osteotomy, so it's something normal. I understand it's not normal in the world today, but become more. The advantage you can, with the percutaneous technique, you can accommodate previous surgical scar, minimal soft tissue dissection, better control of the cut through the medial cortex. I saw lots of people doing mini-invasive osteotomy of the calc with osteotome, chisel, and you go through, you hit the other side. I think with the burr, it's much better. So not a lot of publication. That's, yes, so I have 2 more slides. Okay, so all the publication today shows that you have a better result with the percutaneous ZADEC than any other open procedure. Any other procedure that means Achilles international tendinopathy, and it's actually why we use ZADEC, is for all the Achilles international tendinopathy, as it's bringing forward the high tuberosity, like you do when you do a speed bridge. Finally, what you are doing, you do the resection, but you bring forward the insertion of your Achilles. And with the ZADEC, we do exactly the same without any surgery on the Achilles tendon. The aglune, of course, you can treat all the aglune on the cavus foot. The only consequence you can have is a shortening of the calcaneus, but there is no proof that this shortening of the calcaneus will have an impact on the runner or active sport people, as actually in America they start to do it for even for sport people with insertional tendinopathy. Thank you.
Thank you very much indeed. We'll probably have time for one question. Yul, what are your indication for ZADEC osteotomy in a very simple way? Is it the XY ratio? Is it the calcaneal pitch angle? Or is it your experience in seeing this patient and saying they will benefit from that operation? Because we need to tell our colleagues here when to do it.
Okay. So I do it systematically for all the insertional tendinopathy. Achilles insertional tendinopathy, I don't open it again, never. It's the recovery is completely different. You are not touching the Achilles. You can leave the spur inside, it's not a problem. And it's so powerful, there is no need to touch. So insertional Achilles tendinopathy with no question. After, cavus foot, if it's a cavus foot, I do a ZADEC osteotomy. For me, I just measure the angle alpha. The ratio, everything, I don't look after it. I just, if I have a cavus foot, I want to control the cavus foot. I do my osteotomy to control, to bring back normal angle.
Okay, thank you very much. I think we ran out of time. The next speakers are here. اتفضل لو عندك سؤال. ما جوش، ما حدش واقف على الباب.
So if it's a varus foot, you can fully cut it and translate in the same time. Yes.